Welcome, Internet. Today we're going to be talking about the clinical manifestations of malignant narcissism in the first few sessions of psychotherapy. So here I'm going to talk about a syndrome that was defined in a psychiatric sense by Otto Kernberg. It existed prior to him, but he really brought it in the spotlight. So what is it? Malignant narcissism is basically someone who has a narcissistic personality disorder, but that also feels pleasure in the sadistic experience they can put others through. So that sadism can be a moral sadism, a psychological sadism, like for example mystifying or gaslighting, making the other one feel psychotic, or that they are insufficient, humiliating them, belittling them, breaking them off from the larger environment, and so on and so forth. In malignant narcissism, what is very important is all those things I've just mentioned are egosyntonic, meaning that the person is completely inside of themselves, aware of it, and willing to do it. So therefore it's not about being divided. They enjoy the suffering they inflict. There might also be antisocial behavior, like for example attacking people, hurt, manipulating, extorting, conning people out of their money, and so on and so forth. And they have a paranoid outlook in regards to life. For example, they feel that other people are out to get them, they can very easily feel persecuted, that other people want to hurt them, that they themselves, their mentality is shared by everyone else, everyone is out to hurt each other and everyone enjoys it. It's just that people are pretending that it's not the case. And they might feel also very slighted by anything. Basically, even the slightest remark might be too complicated for them to handle. Therefore, they will lash out, be it verbally, or try and take revenge, and so on and so forth. So you can see that in this syndrome, we're not talking about a standard narcissistic behavior. It goes a tad beyond, and what should I say, 2 to 3 times beyond what could be expected of it. So therefore it's important to know or to be able to spot them relatively quickly for the clinician. So here in this video I'm going to try and tell you what are the main warning signs of it. Here I'm going to be more onto the clinical side of things. This video is really for the professionals. If you ever encounter them or are at risk of encountering them, that the things I'm going to say now might be valuable. My aim also is not to do a clean diagnosis. I'm not saying that there can't be variants where people with malignant narcissism can't be paranoid, having psychotic elements. I don't think it's an exclusive diagnosis that excludes all other stuff, right? It's more that those elements that I mentioned prior are what basically are going to constitute the baseline of malignant narcissism. Very well. Now that I've basically talked about all of this, how does it manifest? Well, often the malignant narcissist, when they come and see a therapist, it's often very interesting because they don't really have a demand. Like, for example, most patients will come with a demand like, I'm depressed, I'm anxious, I'm sorry, I just have this problem and I can't get through, I don't really know what's causing it, and so on and so forth. People have a demand when they come into psychotherapy. The malignant narcissist doesn't really have one. That's first and essential point. A lot of people don't necessarily have them from the get-go, but theirs is very interesting because they don't have it. And in the very first minutes of the session, often what they do is that they try and invert the roles. For example, you're going to ask them, why are you there? And they'll say, no, why have you chosen to be a psychologist, let's say. And then they try and get things out of you. Like they try and ask you, why did you do it? What's your specialty? How long have you worked for? And they try and quiz you, but it's not like they're afraid or anything. It's more that they're trying to get into you to see what is your worth, and if you're even worth engaging with, not in terms of being a psychologist or providing psychotherapy, but really, are you worth engaging as a human? Are you even going to be entertaining in a way? So you might have the feeling that they're inversing, that they are trying to become the therapist and you are becoming somewhat of the patient. it is very important in those dynamics to quickly cut it off and say, we're not here for me, we're here for you. That's why you're paying me. You're not paying me for me to talk about myself. So those can be the very first signs. And often that's a very, at least in my experience, it's a giveaway of their behavior, because they're already starting to twist and to pervert the space of psychotherapy. Afterwards, they might be very, very reluctant to talk about family dynamics. Or if they do, it will be through the prism of an idealized family image, that their parents are always supportive, always loving, that whatever issues they might have, that's purely ontological, i.e. it's part of them, but it's not their families. There's nothing to question, there's nothing to see in those dynamics. Everything's fine, perfect. Here, I think it can be interesting to make the parallel with what Kohut calls a grandiose sense of self, i.e. they're perfect, but especially the idealized parental imagos, they often are unable to criticize their parents whatsoever. Even minor details, right? I mean, no parent is perfect, right? No human is perfect. And often patients can say, that was a bit complicated with my family. My family was nice, but we had these types of issues. And of course, patients should not necessarily trash their family, right? But there's always some points of tension, as there always is, right? In the Malignant Narcissist, they try and paint an ideal picture of a family, of a brilliant family, intellectually, emotionally, and so on and so forth. Sorry. And therefore, what happens is that they basically do not allow any criticism or any doubt of that image. And they will often be very aggressive if the clinician pushes back on that image or says, are you really that sure? There will often be a lot of aggression, or a lot of hidden aggression that they might not unleash because the relationship and the transference is still too young to really lash out, but you can feel the fire beneath the ice. So afterwards, the malignant narcissist will often try and pretend that they know exactly what they're talking about. So what I mean by they play pretend is that they're going to use vocabulary, psychological, psychoanalytical, cognitive, behavioral vocabulary that they've heard or that they've read about, and they're going to use it as like a mantra. For example, they might say things like, I have undone the persona, I am beyond the persona, I am the truest person you'll ever meet, and so on and so forth. Whereas, and then they use the persona in this Jungian sense, so it's already a specialized vocabulary, and they try and put themselves on the same level as the therapist directly, like if they had, it was basically kill or be killed, right, intellectually, like basically it's as if they were fighting a battle, an intellectual battle, and often they might feel basically a little lost if ever the clinician uses another type of vocabulary, because they feel unprepared, because they had made in their mind already an image of what the vocabulary of the clinician would be, and they sometimes they miss because you're not a CBT therapist or you're not a Jungian therapist, and therefore they kind of miss the mark, and they feel that they've lost, like if they had drawn their swords too early, or not in the right, or if they had brought swords to a gunfight, right? So basically they might withdraw at that moment for a little while, or at least in the interaction. But it's very interesting to see that they try and put, to present themselves as an expert of psychotherapy, even though they're not therapists and they haven't trained as therapists. They try and basically show the clinician that they're smart, brilliant, and often when they come with a demand, it is often one of brilliance, like, witness me being brilliant, or could you diagnose me? I mean, it's not as evident as that, but often they try and get the diagnosis of intellectually giftedness, that they're exceptional, brilliant, and they try and feed their narcissism through that, and they try and get the therapist on board with that, and showing the specialized vocabulary is a way of trying to do this, of trying to force or to push the therapist to say, oh, you're incredibly smart, brilliant, and so on and so forth. So they try and create an illusion. They try in a way to fascinate the therapist. And that fascination sometimes tries to go a step further. Like, for example, they might talk about special projects that they have, projects that aim at changing humankind or in improving humankind. So there's a megalomaniac aspect to this, in which basically they're going to try and suscitate a sort of illusion of grandeur in the clinician starting to be, and that's what they seek, is fascinated by them and saying, oh, what an incredible patient, he's going to heal cancer, he's going to find a solution. And that special project is often a mirage, because it's not really real. It's something that they present because they know that people want to hear that. People want to hear that there's going to be a cure for cancer. People want to hear that, they're going to start a special program for handicapped children, that they're going to try and prevent Down syndrome, and so on and so forth. So you see here that the important point is that they try and fascinate, they try and create in the clinician this sense of excitement and thrills, that they are basically the same type of dynamic that they try and do with people in their entourage, like, for example, their partners, or even sometimes their friends. So they try that with the therapist. And what's very interesting is that you as a therapist will often feel uneasiness, a profound sense of strangeness, and it's as if you're gonna be attacked, because technically they are experiencing the world as attacking them, therefore they're attacking as well. Therefore there's a dynamic of kill or be killed that starts to be installed in the relationship very, very early on in this. And often there is this fantasy that, even though they might not say it out loud, that the therapist might be able to see their minds, as if the therapist was gifted with mystical powers. That's the more psychotic end of it. But there is an element of that where they're very afraid. And often they will fear the therapist so much, they will basically fight against all its forms of interpretations from the therapist. They will try and push back against a lot of it. Often when the therapist basically tells them or shows them that they've been, unveiled, that they've been discovered as destructive, as inherently manipulative, they might all withdraw within themselves and present a facade in which they try and basically take back what the interaction has shown and try and rewrite, being in a form of denial of what has happened, or, and sometimes this also happens, or they might feel amused because they feel that this is a form of game and that you have been highly interested because you've seen through what they try and hide. So they might even ask you how to hide it better. But they are at that moment, or they can be fascinated because you've basically seen through them, or they can be very fearful. In my experience, those who are fearful of it have more potential to have a form of standard therapy and try to work on their issues. Those that are amused is a bad prognosis, because basically it's not that they will treat therapy as a game. That's not even it. It's basically it's a form of amusement in which it's a form of competition in which there can only be one winner. Therefore, what's going to happen is that they're going to try and triumph over the therapist. And that's going to basically be what we call in French un rapport de force, which means basically it's a fighting issue in which only one party wins out. Which, when you're doing therapy with a person, that's the worst you can have, because it's not fighting each other. Normally it's helping each other to try and grow and for the patient to go beyond the issues. But here it's not the case, because the patient does not suffer from it. Well, not if they have malignant narcissism. Therefore, basically it's a fight, and what they want is to triumph over the therapist, to show him that therapy is basically, it's a con, it's a con, it's not real, that words don't heal, that nothing heals, and that there's only suffering, and that Basically, they're there to show the therapist that he's completely wrong. If he isn't like them secretly, because that's also the fantasy, is that the therapist would be like them on a secret level, on a unconscious level, the therapist is like them. Therefore, it's like a merger between both of them. But if the therapist is not like them, the whole goal is to show them that they're wrong and that everything is wrong and that the only true way is their way. And often they will present the therapist in the first few sessions with a form of ideology. So that ideology can be very different from person to person, right? It can be a political ideology, it can be societal ideology, it can be a medical ideology, whatever, right? But they will present that ideology or that perspective as absolute truth. They will not allow any wiggle room. They will not allow the clinician, for example, to be curious about it or to question it, because it's the dogma, it's the absolute truth that they want to, not that they would just want to believe in, because yes, they want to believe in it, but they also want to project it as an absolute truth onto the other. What they want to be is the master. Therefore, the master wants one sin, slaves. And that's what they try and do with a therapist. They all try and enslave him, or try and basically have a fight, verbally, intellectually, and psychically with them, in order to triumph over them. Because in a way they enjoy the destructivity of the relationship, but not the loving, caring part of it. That has it, basically they feel disgusted by that, because they've never had that, have never experienced it. It's all seen as fake, as basically a ruse that humans play on each other. It's not seen as real. Therefore, during these sessions, the clinical psychologist might feel, or therapist might feel a massive amount of destructivity in the relationship. And something is wrong and should not be there. Like if, like for example, you're trying to put a square in a triangular shape, it's not going to work. And something in you, when you're in your countertransference, shows that, as if there was something wrong, something that was not supposed to be there, or even that the patient is a threat. That's something I think is a very powerful insight, countertransferentially. And one of the main signs, I think, of malignant narcissism is that you can't be neutral towards these types of people, or even having a positive regard. It doesn't work that way with them. It's as if they were creating the recipe for a destructive interaction, even with a therapist. Therefore, it is very, very noticeable. And often in the first few sessions, I think that countertransference is super important. One of the most important tools. It's always important, but for them, it is so essential to trust yourself. If you feel destructivity, that means that there are destructivity. And often the malignant narcissist will not be upfront with that. It's only later on that they will tell you that they've, for example, wrecked the life of their ex-wives, or wrecked their former company, or destroyed this, or destroyed that. But the premises of it is something that you can feel. You can feel that. Because even though they try and hide it, it still emanates from them. Because truth is, it's not something that you can masquerade, really. It's something that just emanates. It's just part of who they are, of their global personality. Therefore, they can't really hide it. Or at least that's what I've found. In the first few sessions, you tend to see it seeping through. So, just to recap, there's basically three big sins that basically are the warning signs of malignant narcissism. First and foremost, they try and invert the therapy, get the therapist to talk about themselves or even other patients. They try and twist it as if the therapist was in the place of the patient and the patient was the therapist. Second, they try and fascinate, of creating an excitement, an illusion, an allure that the therapist is meant to just basically fall into, so that they can manipulate them and have them basically as a sidekick for their projects, or to try and manipulate others. For example, later on they might say things like, my therapist tell me this, he said that you're this or that. I mean, when they're not overtly lying, sometimes certain therapists can unfortunately fall down the drain of being fascinated by them, and it's not necessarily because it's bad therapists is that the patient's projective identification, i.e. projecting that fascination into them, is so strong, so powerful, that sometimes we are uncritical of that. But that doesn't mean that it's always the case. Sometimes it fails and you can see it for what it is, a trick. And thirdly, there's a destructive element that is very present inside of the relationship. You can feel it, you can feel its echoes and its effects, and that's really something that should put you on the, how can I say, on the idea of a malignant patient, that it's something that you feel, and you feel under threat, or you feel so aggressive, that's something that's unusual. If no other patient triggers that in you, that is a sign, and I think it's a very important sign. One of the most important is countertransference, i.e. what we feel for the patient. So I hope you found this video interesting, because I've pretty much done my part and said what I had to say. If you want to add anything, because it's a very complicated topic and I know that a lot of people have a lot of thoughts about it, I just wanted to make this video because I think that can help our professionals just detect them and perhaps even protect themselves from the influence of those types of patients. Again, I'm not trying to demonize them. They're human beings who have often experienced so much abuse and trauma that it basically carved their path. That doesn't mean it's an excuse, far from it. It excuses nothing, but we still have to retain the fact that they're humans, because if we are keen to dehumanize them, then they get what they want. They're no longer considered part of humanity, therefore they're completely rejected and put away, thrown away. Whereas I think that reintegrating them to humanity, it's difficult, and that doesn't mean we have to tolerate anything, but they are human, and that's, I think, what we owe them and what we owe to ourselves. Because once we reject them, we prove them right, that they're not worth humanity, and therefore their whole system of thought, their whole paranoid perception becomes true, and therefore basically by ejecting them, we're proving them right, and I think that that's not the way to go, at least from my perspective. So basically, that was the video. As I was saying, it's a very complicated, nuanced topic, and I'm not saying that I have the answers, but I found that it's important, it's interesting to talk about it, especially because younger clinicians who have not encountered these types of patients can feel lost. So if it can at least bring some form of clarity, that could be nice. Anyway, I'll end it for today, and I'll see you in the next one.